In this video, we present the management of a subluxated cataract. A 11-year-old child presented with a history of diminished vision in the left eye with a refraction of minus 5.75 diopters and a cylindrical error of minus 11.25 cylinder at 85 degrees. He had a nasal grossly subluxated lens with a lens coloboma and a posterior subcapsular cataract. The management strategies in this case, options would be a lensectomy with vitrectomy or an intraocular implantation in the primary or a secondary setting using either a scleral fixated IOL, a glued IOL or a retrofixated iris claw IOL. What we did in this case was a lens aspiration and an in-the-bag intraocular lens implantation using a modified CTR. The biometry showed intraocular lens power of 23.5 diopters. However, the corneal astigmatism was just 1.77 diopters, indicating that most of the manifest astigmatism was lenticular in origin. We took up the patient under a guarded prognosis and under local anesthesia with sedation. We made a partial thickness scleral flap nasally at the point of maximum subluxation, 2 side ports for the irrigation and aspiration and 2 side ports for the capsular hooks were made. The continuous curvilinear capsular axis in this patient was of utmost importance as we would need to use a modified capsular tension ring in this case. 2 olive-tipped capsular hooks were gently inserted under the capsular rim for better stability of the bag. A gentle hydrodissection was then performed and an irrigation aspiration of the lens was then gently done without any fluctuations in the anterior chamber so as to prevent any increase in the amount of subluxation. The Sionis ring was then taken and it was threaded outside with a 90 proline suture. It was then inserted through the main incision into the capsular bag and it was rotated such that the eyelet came to place in the nasal side, which was the site of the maximum subluxation. The capsular hooks were then removed. A bent 26 number needle was then inserted underneath the partial thickness scleral flap and the straight needle of the 90 proline suture was railroaded from the main incision. The procedure was then repeated with the other end of the suture and the 2 ends were then tied. A 3-piece intraocular lens was then placed into the capsular bag and the lens was well centered and the main incision and the partial thickness scleral flap and the conjunctival flap were then closed. Postoperatively, the child did very well with a vision of 6/18 partial. The suboptimal vision was due to amblyopia. Thank you very much for watching.